As an endodontist, I think that the product Biodentine is very, very valuable, both for general dentists and for endodontists. And one of the main reasons is it's able to save teeth, and particularly dentin. In so many areas, we notice that dentin is missing, whether it's from resorption. I do resorption repairs with Biodentine. Whether it's dentin that's missing due to caries, and so you need to place a direct or an indirect pulp cap, or whether it's due to a perforation, maybe it was even iatrogenic. These things can be repaired with Biodentine, and they can help us save teeth. In restorative dentistry, why would it be valuable to consider the placement of a direct pulp cap with Biodentine rather than jumping straight to endo? Imagine that you're excavating caries and you know that the patient has had symptoms of reversible pulpitis, or maybe even mild irreversible pulpitis. Maybe the tooth is even a little percussion sensitive. There could be some PDL widening. By the way, PDL widening signifies that inflammation has reached the apex, not necessarily infection. So it's important to distinguish between PDL widening, which is a transient apical breakdown, versus a true periapical radiolucency. Okay, so imagine we've got this patient with deep caries, maybe some biting sensitivity, they have some cold sensitivity on and off, deep caries, and we're like, they're gonna need endo. Why would it still be valuable to try to place a direct pulp cap and restore this case without endo? The reason why is this is part of a continuum of care. Imagine, you go from step A to B to C, D, E. You're moving through all of these options for a tooth. When we have a really good product like Biodentine, which is biocompatible and a dentin replacement, we find the success rates of direct pulp caps are very, very high. And even these cases that have PDL widening or have mild pulpal symptoms tend to resolve. Now, if the patient in the future, maybe 5-10 years from now, maybe they will need endo. It's certainly possible. But the thing is we can buy time with this tooth being vital. We should try everything we can to progress through those options, A, B, C, D, E, before just jumping to Z. So why should a general dentist place Biodentine on a pulp exposure when they're going to send the patient for endo anyway? Maybe the dentist needs a post space, therefore endo is required for restorative purposes. Should they really place Biodentine as a direct pulp cap in that interim? I would say as an endodontist that the answer is yes. Even though this is not a permanent treatment in this particular case, I would say that placing a direct pulp cap with Biodentine, even if you know they need elective endo for restorative purposes, it's still beneficial because it can help keep the pulp vital, and endo success rates are higher when a patient has vital pulp. In addition to that, when you have a pulp exposure and you don't place something biocompatible on that pulp exposure, even in the process of waiting for the root canal appointment, 1, 2, 3 weeks, however long it might be before they go into the endodontist, during that time, pulp necrosis can occur, and I have had patients who have told me they were fine for a few days, but then they had to go to the emergency room because they were having severe pain and swelling. So I would like us to be able to prevent these and to have better outcomes for our patients. So even if you know that your patient needs endo for elective purposes, such as needing to place a post in order to restore the tooth, even if they need endo for those reasons, I still think it's valuable to place a direct pulp cap and keep the pulp vital in the interim.